wrap up this session. So invariably, refraction is the last part of your clinical exam. And so in this talk, I will give you some pearls for taking up this clinical exam in refraction. Right. So on the day of clinical exam in the morning, you are tired with, or you just go on a roller coaster ride like what we had in the morning, Dr. VRV's talk, and followed by the OSCE. So refraction is probably the last part of your mind, and if you're not done in the morning, not done well in the morning session, this light can really lead you towards some hope, and for many of them it's a savior. Right, why you should learn refraction? Because it's part of your syllabus, but it's very, very important once you get your PG done and go for practice. So this assessment of refractive errors and prescription of glasses is very essential for your practice after your clinical exam. So working knowledge is really needed to prescribe lenses and frames, and also need to know something about the process of dispensing, because it ensures patient satisfaction. So a few tips on for the exam. Why you should learn retinoscopy, because ophthalmology, as you know, it encompasses the finest art on earth, and retinoscopy is one of them, because it is an art. You need to really learn as well as practice. It's not like something you can mug. So to join this elite club, you should learn this art. And while doing refraction, you have to be relaxed, otherwise you will miss a lot of findings, particularly the light reflex. So you have to be calm and composed. And when presenting a refraction case, final diagnosis is easy. You already know the diagnosis, but you need to master the steps. So the exact treatment and the practical aspects you already know. So you need to really master the steps of retinoscopy and then the methodology of presenting the case. A daily work diary will be really helpful, and if you are not doing well, a glance into the logbook by the examiner will have a good impression on you. Some of the exams, they don't allow you to take the history, but it will, if you are taking the history, it will be a good guidance. So power of present glasses, or if they are wearing contact lenses, the power of lenses. History of systemic disorders like diabetes or any other chronic illness will be really useful, and you have to elicit the family history also, particularly myopia and related illness like squint. And symptoms of double vision, I say don't think of difficult neuro-ophthalmic diagnosis. Even simple refractive error can also lead to eye strain, headaches, squinting and glare, etc. And you also need to know their occupation, so you need to know their visual demand, so that whether driver, painter, surgeon or student or IT professional. Of late, a lot of patients who have to work in the mid-range distance. So all these people have unique needs, so you need to ascertain their visual demands and request if you are going to prescribe glasses. So preliminary exam also includes having the visual acuity, ocular motility and binocular function, and you also need to do cover test, corneal reflex test, and motility as well as pupillary function test. And if they are already wearing glasses, you need to check the present glasses, see that in front of the observer or examiner, because they keep a keen watch on you whether you are doing it in a right way. So generally these are some of the questions on retinoscopy. Why should you do it, and why is it important? What information or data you ascertain from the retinoscopy, and some of them can ask this, how it is different from the autorefractor. So you know there are two types of retinoscopy, static and dynamic. Static is for routine refractions with a patient viewing at a distant target, and dynamic is when the patient is focusing on a near targets. So this helps to determine the accommodation and residual accommodation if you are doing a cycloplegic refraction. So some basic principle you have to bear in mind. The aim of retinoscopy is to find the lens which will stop the reflex movement. This is basically the aim and why you want to do this retinoscopy. So you need to view through the sight hole. So look through the retinoscope, you will see the red reflex. And the first step is to see the red reflex, and generally this red reflex looks like a narrow band, and that covers part of the pupil. So if it is not seen, that means it's a hazy media, so you will know whether the media is clear or not. And then focus on the retinoscopic reflex on the pupil. And if you are using a streak, light from the streak on the trial lens rim. So you'll see the movement, so either with movement or against movements or no movement. These are the two things you want to concentrate. So with movement is something like this. The reflex moves in the same direction as the sweeping motion of the streak. So it is called with movement. Against movement is the same thing. It's against the reflex moves in the opposite direction of the sweeping movement. So this is called the against movement. So the idea is to neutralize these two movements, whatever case you get, so that where there is no movement. So you need to adjust according to the distance. And basically this is the general algorithms. See that the movement is with or against, first step. Second, if it's a with movement, add a positive lens. If it is against movement, add a negative lens or minus lens. And you also need to see whether the reflex is bright or dull. If it is dull, see to that it has to be. If it's dull, then start with a relatively higher power. And if it is bright, that means you are getting closer to neutralization. So these are the three important steps in retinoscopy. To make it further simplified, so this is the tabular column, right? So if in practice, most of them tend to use this so-called computerized eyes testing with all its pros and cons. It has become a necessary fixture, so you can't do without this in practice. You also need to verify whether your refraction is right or not, then duochrome test will help. And this is the general ruling on giving the near vision aid. I think you all know this. And the accepted prescription model is this. There are certain ways of giving it. You need to write the spherical part, cylindrical part, and then axis, and then give the reading gap. And if there is a prism, you need to add prism for this. Few questions on the indications for cycloplegics and the duration of action of each cycloplegics you also need to learn. And for all patients less than 10 years, cycloplegic refraction is mandated. And if you suspect accommodative spasm, again, cycloplegic refractions. And if there is a squint, you need to do cyclorefraction. And patients below the age of 30 years with manifest hypermetropia. And if there is a gross difference between dynamic and the present power, you need to do a cycloplegic refraction. And if there are symptoms, symptomatic patients with or without glasses, you can do. So these are some of the indications for cycloplegic refraction. And if you do cycloplegic refraction, you have to ask them to come for a post-mediatic test or post-cycloplegic refraction. And so only when dynamic or static refraction show different axis and power. And date for PMT usually varies. So these are oft-repeated questions in the viva or refraction cases. When will you ask the patient to come for cyclorefraction? So it all depends on the type of cycloplegic use. If it's atropine after 2 weeks, and homatropine after 48 or 72 hours, and tropicamide after 1 day. Transfusion, Dr. Chandrasekhar has already dealt with this in the OSCE, so I will just skip this part because it's a bit difficult. So basically this is the rule. Cylindrical power stays the same. Cylindrical sign always changes. The cylindrical axis changes by 90. So then you add the orbit sphere curve. So curves for refraction or refraction case, write the complete diagnosis, and you can also write. Okay, so that's the thing about refraction. Any question we can discuss later.